Good afternoon, good morning, and good evening, depending on where in the world you are plugging in from. This is a Global Brain Health Clinical Exchange platform. It's my pleasure to welcome you. We're going to spend just a couple of first minutes waiting for everyone to join us. I can see that the numbers are rising. And so please, as you are coming in, do type in the chat box where you're joining us from. What's your background? Are you sort of from a student? Are you in residency? Do you work in policy in an NGO? We'll be very curious to know that, and also where you're joining from and what you're hoping to get out of the session. Just a note to say that also this workshop is being recorded. We like having a collection of our previous webinars so that they can be watched on demand from our website. And we'll mention that also at the end of the session. So just waiting for the registrations to come up. I can see there are still people coming in. Welcome from Pakistan, and we have an ophthalmologist. Please pop your countries, your affiliations. And we do have 90 countries registered today for the session. We have United Kingdom, welcome. Had a number of registrations from India, from Kenya, from Nigeria, but we have almost pretty much all continents represented: Gabon, South Africa, Norway, excellent, thank you. Netherlands, Portugal, that's great. So we're just gonna give it another minute, and then we're gonna get started as the introductions are coming in, which is great. Okay, so we have now 2 minutes past 9, so I hope more will be joining, but we're gonna get started. And I'm gonna introduce our speaker. But first of all, my name is Arina Tamborska. I'm a neurologist, a physician, and also a researcher. I am based at the T.H. Chan School of Public Health in Boston at Harvard University. And I am also affiliated with the University of Liverpool, which is where the clinical exchange platform originated and was started in 2020. And this is the university that funds and hosts the platform together with the Global Exchange, Global Health Network. We originally started the platform in 2020 in the midst of the COVID pandemic, and that was in the recognition that we want to share knowledge and experience on a disease that we knew quite little about. And we wanted to pull sort of all the available information, learn from what we're noticing in other settings, and also learn how to tackle sort of global problem. But as the time progressed, we've noticed that there's an appetite and also a demand for sharing not only knowledge about the COVID-19, but also about neurological care in general, and that there's plenty we could learn from each other, from the sort of clinical backgrounds, but also non-clinical backgrounds on providing the best care for patients with brain disorders. We did notice that as IGAP was coming up from the WHO in May 2022, there was also increased demand not only for learning about the management of clinical conditions, but also learning about how we can make the systems better and how we can build capacity in care for global brain health. We then wanted to collaborate with a number of institutions and organizations, and over the last 2 years, we've had presenters coming from various sectors, including NGOs, including policy, including WHO. But one thing that became also apparent to us is that we also want to collaborate not for different settings or different organizations, but also different medical and clinical specialties. And in particular, that's why it's my absolute pleasure in this context to have a collaboration with our colleagues from the Neurosurgery. And this is the sort of first collaboration like that we are doing. So I'm really glad, and I'm sure we can learn a lot from each other. The chair for today's session is Dr. Kee Park, who is a neurosurgeon, a WHO consultant, and an expert in capacity building in surgery globally. He's also a committed advocate for global brain health, and I'm delighted to have Kee with us today. Dr. Park trained in Philadelphia, but practiced neurosurgery around the world, and his clinical experience has taken him to Addis Ababa in Ethiopia to work as the head of the spine and brain surgery there, and then also as a director of the Cambodia Neurosurgical Support Project by the World Federation of Neurosurgery. He gained further experience in building capacity in neurosurgical settings. After that, he became a fellow of the program in the global surgery and social change at the Harvard Medical School, and then a faculty member. And during that time, he also co-founded a global surgery foundation, which seeks to sort of build collaborations between member states and the WHO and United Nations in supporting countries and introducing national surgical plans. And actually one country to do so very recently, I think last week, was Ecuador, so a huge success in that field. So Dr. Park is currently a director of the Policy and Advocacy program in global surgery at the Harvard Medical School, and he remembers an advisor and an expert to many international committees, including WHO, World Federation of Neurosurgery, and American Board of Neurological Surgery. So plenty of commitment and plenty of experience in that area, and we are really delighted to have you join us, Key, to lead this exchange platform. So I'll pass on to you to kick off the session and introduce our speakers, and we are very pleased to have you with us.
Well, thank you, Arina, for that kind introduction. I just want to say thank you to you, to Victoria, and the rest of the team at Liverpool. It's been a great experience organizing this session. I'm particularly thrilled that as neurosurgeons, and we have 3 neurosurgeons joining today, we're able to engage with neurologists, nurses, neuroscientists. And I think I want to give credit to WHO for this. WHO gets a lot of, criticism sometimes in saying, oh, they're useless. Well, I tell you, in terms of the intersectoral global action plan for epilepsy and neurological conditions, which was passed last year at the World Health Assembly, it fosters intersectoral cooperation. So here we go. This is a kind of a result of the IGAP being implemented, at least at the academic level. So we hope to see more collaboration, intersectoral collaboration, and don't think that neurosurgeons would like to just work by ourselves. We love engaging with people outside of our communities. We have a really special conversation today with the 2 of my colleagues and friends. One is Ebenezer, and the other is Tariq. The 3 of us are neurosurgeons. Ebenezer has been working in Ethiopia. As I recall, in 15 years ago, there were only 3 neurosurgeons in all of Ethiopia. And then you will hear a incredible story, a success story of how, at least in Ethiopia, they have been able to scale up the workforce and improve delivery of neurosurgical care. And then we'll have a short talk from Tariq Khan, who's in Peshawar, Pakistan. And Tariq is a neurotrauma specialist, has been involved with the World Federation of Neurosurgical Societies for quite some time, chair of the neurotrauma committee. But he's moved towards more policy and more overall global capacity building type of efforts as part of the Global Neurosurgery Committee member. So we'll start with Ethiopia, hear the story. We'll zoom out a little bit, hear the story from Tariq. 10-minute talks from each. We'll have a conversation, and then we'll try to wrap up by 55 after the hour. So thank you all for joining. Let's start off with Ebenezer with your first talk.
Thank you very much, Prof. Kipa, for the kind introduction and invitation. Also, thank you, the Global Health Network team, for the invitation, and I'm sharing my screen. So is that okay? Yeah. So I'll be talking briefly about our experience in Ethiopia in building the neurosurgical capacity. So this is the outline of my presentation. So Ethiopia is located in the eastern part of Africa, and it's the 2nd most populous country in Africa currently, with a population size of around 120 million, and 80% of the people live in the urban areas, and it's a low-income country, according to the World Bank report. Despite that, only around 5% of our annual GDP is allocated for health expenditure, and this is one of the challenges we have, and it's relevant to our talk today. So as stated by Institute of Medicine, by the University of Washington, so the quality healthcare has 6 pillars, and it's the same for the neurological care. So it shares these pillars. So one is the workforce. So we have to have a good number and well-trained and skilled human resource. And the other is we have to have a well-running system which will be able to improve the access and organization of care to our patient. And there should be a governance structure which helps to have a sustainable and self-sufficient running service. And the other is we have to know the population which we are serving. We have to know the community, and individual-based care is very important. And the last and the other important component of quality healthcare is the tools. So we have to have from the basic to a well advanced equipment and machines, and we have to have a good way of health data. So this is what we aspire to have in the future. And in the last decade, we were able to achieve some success regarding to the rapid increment in human resource development, and as well as not only the number but the quality of the service and the education we give had gradually been improving. And we are doing more number of cases, more number of complex cases, and with reasonably better outcomes. So we have a lot to improve. And the other important achievement we had was we were able to support trainings for colleagues from other sub-Saharan African countries. And in ASCII said in 2006, there were only 3 neurosurgeons, and through the local initiative and international partnership, we were able to achieve some of the achievement we had. And from the important achievement we had is one is a south-to-south collaboration. So currently we have institutional collaboration with Kamuzu Central Hospital in Lilongwe and Malawi. Our colleagues go there to work with our colleague, local neurosurgeon who is based in that hospital. And we also have a chance to support training programs for residents coming from other African, sub-Saharan African countries. So we did a survey in 2021 to evaluating all the neurosurgeons and neurosurgical residents in Ethiopia. And neurosurgery is the workforce is mostly young, so most neurosurgeons are on their third decade of life. And when we see the performance audit, so on average, most neurosurgeons perform from 150 to 200 major neurosurgical cases every year. And when we see based on institutions, so most institutions perform from 500 to 750 major neurosurgical operation. And when we see the institutions or hospitals with a residency program versus the others, so the hospital with a residency program have the maximum performance, and these institutes perform more than 1,250 major neurosurgical cases yearly. And this is a good achievement comparing to what we were like a decade back. And when we see the access to neurosurgical care in Ethiopia, so currently we have around 12 cities outside the capital Addis with some neurosurgical services, and almost most major cities are covered. And for at least for emergency services in urban setups, almost more than 50% of the neurosurgeons responded that the emergency neurosurgical cases will reach to the hospitals in less than 4 hours. But this is only true mostly for urban areas, and this also needs a lot of improvement at the urban as well as the rural parts. And when we see the facilities, most facilities are like WFNS level 1 and 2. They only have the basic sets, and almost 98% of the neurosurgeons use a manual drill. And like they have the basic laminectomy, craniotomy set, and 71% have access to shunt hardwares, and CT scan is available in centers where 62% of the neurosurgeons are performing. But when we see a reasonably advanced equipment like operating microscopes, C-arm, electric drills, MRI and endoscopes. These are only found on the major cities, and they are like most neurosurgeons still in our country doesn't have access to these equipment. And beyond this, so the most advanced equipments are not yet available in almost all parts of the countries. When we come to the training program, so currently we have 3 training programs. So Addis Ababa University program being the pioneer. So it has it graduated most neurosurgeons, and it has the most number of neurosurgeons currently. And we have a second program, which is a young and a vibrant groups like working at the other hospitals in the capital. This is a St. Paul program. And we have the third program at Mekelle University, which is the first program to be started outside the capital cities. So most neurosurgeons come from almost most medical schools in the country, but still the Addis Ababa University Medical School provide most trainees. And when we see the trainees, so they respond that they perform from 100 to 150 major neurosurgical cases yearly, and they work from 60 to 80 hours per week. And they are well versed with doing neurotraumas and neural tube defects and hydrocephalus surgeries, but they believe that they want more exposure in vascular, endoscopic, epilepsy, craniofacial, and tumor surgeries, and they want to have a subspecialty attachment in fields like spine, skull-based vascular, and functional neurosurgeries. When we see the research output, so the research output in the last 10-15 years had significant improvement, especially in the last 3 years, and most research proportion of international collaborative works. So this is one of the progress. And when we see the areas where mostly researched, so human resource related research are quite common, and the other is service related and infrastructure related research are also common. We also see treatment outcome and comparison of treatment outcome research currently, but we need to work more on these areas. So when we see our gaps, currently we have only 4 neurosurgeons in Ethiopia, and there were only 3 during the time of the surveys. And most neurosurgeons, almost 90%, are a general neurosurgeon, and we don't yet have subspecialty trainings. And the other is like most of us want to have a subspecialty trainings, and when when the neurosurgeons were requested, so most want to have a subspecialty training in facilities with a good experience. So they want to be trained abroad for observership or fellowship, but they want to be trained as a team, not alone, so that they can come back and start the service again. So in conclusion, so we had a self-sufficient and sustainable training program, and services and global partnership are invaluable, and the program can be exemplary for other similar settings. And we need further collaboration in improvement in the outcomes and quality of our works, and we need much support in infrastructure development and subspecialty development. So thank you very much.
Yeah, Ebenezer, congratulations. It's really a success story and a model that, for other countries to follow, the rapid increase in the neurosurgical workforce. Was there a poll that you were going to do today at this time, or do we move on to Tariq? Did we do a poll?
The poll was in between, like the.
Oh, here we go. Here's the poll right here. So we want the participants to stay awake to take this poll. Okay, I did mine. Thank you. All right. Now we move to much global perspective with Professor Tariq. Tariq, are you ready? Oh, here's the poll results. Hold on 1 second. Ebenezer, what's the right answer?
The right answer is C. So we currently have 87 neurosurgeons and 83 residents, neurosurgical residents in training in the 3 programs.
Okay, great. That's amazing. Went from 3 to 87. And you have as many neurosurgery trainees as you have neurosurgeons. So it will double very quickly. Congratulations. Okay. Tariq, over to you.
Yeah, hi. Hello from Peshawar, Pakistan. Thanks very much for inviting me to this very important meeting on Brain Health Clinical Exchange Program. So this is where I work in Peshawar, in Northwest School of Medicine. So I'm going to talk about the comprehensive policy recommendations for head and spine injury care in lower and middle income countries. Now, these are policy recommendations. These are not recommendations for neurosurgeons per se, but for anybody who is into policy. And we hope that neurosurgeons and neurologists and other people, nurses, etc., would be into policy. So it's a good thing for them. So this was done with the help of the Program for Global Surgery and Social Change from Boston with the lead Key Park and myself. And we had a large advisory group from many countries: Nigeria, Colombia, Belgium, USA, Tanzania, Pakistan, Ethiopia, Switzerland, and many other countries, really. So it's a collaboration of people from different countries. And we had a nice technical team who helped us, and definitely we acknowledge a number of people like Faith, Elena, Liku, Shu, and Sarah. So the vision was that no person should experience undue disability or death due to head and spine injuries, regardless of where they live. And the aim was to develop system-level policy recommendations for reduction of death and disability from brain and spine injury in low and middle-income countries. So we all know maybe the Lancet Commission report about how many people do not have access to safe, affordable surgical, obstetric, and anesthesia care, and that 143 million additional surgical procedures are needed in MICs each year, and that 33 million individuals face catastrophic health expenditure due to payments for these procedures. So we need to invest in surgical services which are affordable and save lives and promote economic growth. So this was from the Lancet Commission in 2015 on global surgery. So what it said was that we need a robust surgical system, which is, is a cornerstone for universal health coverage. So if you look at it, these are old figures, but 74% of surgeries for TBI are needed in LMICs, and 89% of surgeries for traumatic spine injuries occur in lower and middle income countries. So neurosurgical diseases represent a significant proportion of the unmet surgical need. And according to the executive summary of the Global Neurosurgery Initiative and the Program in Global Surgery and Social Change, there are estimated 22.6 million patients globally who suffer from neurological disorders that warrant a neurosurgical evaluation. And of these, 13.8 million individuals would require surgery. So it is a very big number and require almost 5 million cases per year in this category. A number of factors in LMICs contribute to the significant morbidity and mortality, and the potential barriers to providing surgical care is lack of effective political advocacy, insufficient resources, and a perception that surgical intervention is not cost-effective by population-based measures. So I believe that you people would be aware of the National Surgical Obstetric and Anesthetic Plan, again, which was helped very much by the Program for Global Surgery and Social Change, and regarding going for universal health coverage by 2030, according to the WHO goals. So these were 6 components: infrastructure, workforce, service delivery, financing, information management, and governance. And what we looked at for the management of brain and spine injuries was surveillance, prevention, pre-hospital care, surgical system, and rehabilitation. And we developed a recommendation matrix connecting the two, the WHO and the comprehensive recommendations for brain and spine injuries. And the first one and most important was to develop a surveillance system, innovate, which is a priority for countries lacking computerized health data, using trauma registries with neurotrauma data elements as the key surveillance data source for Ministry of Health. And a lot of work has been done to develop neurotrauma registries by the NHR program in Cambridge. And also that Ministries of Health must recognize engaged leadership for neurotrauma surveillance as a governmental responsibility. So we needed to try and develop platforms so that they could integrate effective surveillance systems because you need data handling platforms for that. And so police reports, vital registries, health surveys, information systems, and national insurance records. And to design and develop these platforms, therefore, requirement for effective national surveillance of neurotrauma. So we need to leverage the international partnership for the surveillance and then develop fit-for-purpose workforce for this data collection, analysis, and interpretation. And align international collaborations to support local workforce capacity. As I said that through these platforms, through developing the registries, we would know how many patients there are and then connect internationally like we did with Cambridge and develop these. And then flexible and strategic use, task shifting and task sharing to optimize human resource. So service delivery, that minimum data which is required is demographic information, coded diagnosis using the ICD, mechanism and circumstance of injury, severity using coded indices such as the Glasgow Coma scale and the injury severity score, and outcome measures such as cervical status, hospital length of stay, or Glasgow outcome scale. So the most important thing we found then in this was the prevention, which is my favorite topic, and enforcement of existing regulations and laws, comprehensive mandatory helmet law, and then well-designed and properly maintained road infrastructure. Because this is what we deal with in our countries, and it's very common to see in a lot of lower-income countries. And as I keep on telling them that we need to get into the Guinness Book of Records and want to see that one helmet protects everybody. This survey showed, which we did in 2016-17, that majority of the people did not wear helmets and seatbelts, and this was a survey from Indonesia, Pakistan, and India. And so we started with prevention is better than cure, and we started this activity with public awareness seminars, poster competitions, etc. And then we joined hands with the Think First International Prevention Foundation to have public awareness seminars, and the first one was done in Peshawar in 2019. And we must learn from the lessons from Vietnam's helmet law. On one day, they decided that everybody must wear a helmet, and it made a massive difference to the morbidity and mortality. Then the most important, again, is pre-hospital care. To develop a contextualized pre-hospital system, emergency medical personnel should be trained in neurotrauma care, and time from injury to a neurotrauma facility should not exceed 4 hours. And when we looked at this study, when we did in 2016, majority who provided the emergency care at the scene of injury were lay people, and nobody traveled with the patient to the hospital in the ambulance. There was no nurse or no nursing assistant with them. And the duration of surgery was very, very long, sometimes even up to 24 hours in that. And we know that 50% of patients die from TBI do so within 2 hours, and 40% of pre-hospital deaths are potentially preventable. So this data shows that how many people died in lower-income countries compared to high-income countries. So we recommend limiting hospital transport times for TBI to a period not exceeding 4 hours in that, because we saw that in particular, expediting patient transport within 4 hours window for type of injury associated with better outcomes than admission following longer time frames. Surgical systems, again, we need to have at least one neurosurgeon for 200,000 people, and neurotrauma services should be embedded in the surgical package within universal health coverage. 80% population should be within 4 hours, and we know that the 30% mortality for subdural hematomas operated within 4 hours and 90% mortality after 4 hours. And we need to strengthen the pre-existing infrastructure by task sharing, task shifting, increasing the number of neurosurgeons, and somehow dramatically increasing their workforce. And we know that this type of work was done in Australia, where far distant areas people could not travel the neurosurgeons, so they were training some general surgeons to do the work. Now, with the help of training and feedback, teleradiology, virtual surgical assistant, and guidelines, it may be easier to do task shifting and sharing with these people. Service delivery, standardization of equipment like basic sets being supplied by the World Federation of Neurosurgical Societies Foundation, which has done a lot of work trying to help CT scans in all neurotrauma facilities, critical care facilities leveraging telemedicine, and innovation like battery-powered equipment, cheap shunts, ETVs, infrascanners to detect hematomas, etc. And then embed, as I said, neurotrauma in universal health coverage and international partnerships. And when we developed the National Vision for Surgical Care 2025, again, with the help of the Program for Global Surgery and Social Change in Pakistan, we embedded head trauma and hydrocephalus into this program so that we can help improve services for people. Then information management to track neurosurgical workforce and operative mortality, neurotrauma registries, WFNS, neurosurgery workforce mapping project, and neurosurgery capacity access map. And this global epidemiology of traumatic brain injury registry is being worked with by NIHR in Cambridge with many countries, including Pakistan. And of course, Key Park was very instrumental in developing this global neurosurgical workforce map, which has helped us know exactly where the neurosurgeons are and what are their requirements in that area so we can help them. And now we are working on a project to try and have neurotrauma as a notifiable disease so that with that we can leverage the governments to increase spending in helping neurotrauma care and spine trauma care in that. Rehabilitation is something people forget, or it's the most expensive thing which can do. So to develop physical space, facilities, and durable medical equipment, and promote active involvement from the family and community. And we are working now with community as well in Peshawar. We have taken up a project with Cambridge NIHR, and one of our doctors, Dr. Almas, is working with that to talk to the community, talk to the patients, talk to the relatives. To do that. I think that is very important. And we're trying to train family members to help in rehabilitation as well. Because when we looked that all the neurotrauma patients, majority were sent home to their families to look after them. So in the end, I would like to invite you to write in this very important journal, the Global Neurosurgery Journal, part of the Red Journal of Neurosurgery. And this is the editorial committee, and we welcome your papers into this. And I would like to invite everybody to the first WFNS International Global Neurosurgery Conference to Peshawar next year. Thank you very much.
Thank you, Tariq.
I'm sorry for rushing.
No, this has been great. The work that you have done, at least informing ministries of health and how to improve neurosurgical care, especially in terms of trauma care, is super valuable. Typically, clinicians, and we have many of them in this group, we tend to focus on per patient, right? But really, to make a change at the country level, we have to engage the health system and a comprehensive approach to these conditions. We do have a very active chat that's going on, and let me start off with a question from the chat. And this is to both Tariq and Ebenezer. We'll start, Ebenezer, with your answer first. And the question has to do with neuropsychology. Do you have neuropsychology services, let's say in Ethiopia? And if not, what are some ways we can get that introduced? Ebenezer?
Thank you very much. Yeah, I think that will be a very important part of the service and care we give. There are neuropsychological services in some hospitals, like public and private hospitals, but they are not well integrated. And in our clinical practice, we don't actively communicate. We just refer patients, and we don't have platform like to work together and in managing patients. So I guess this will be a very important thing, and we look forward to work on that regard.
Great, thanks, Ebenezer. Tariq, how about in Peshawar?
Yes, thank you. Seriously, it is definitely a very important thing for head trauma patients, and even for patients who become paraplegic from spinal injuries. Unfortunately, although we have psychologists, we do not have neuropsychologists as such psychologists, and I think it is very important. I think we should look into it and try and involve them with us. Thank you very much for this question. I think whoever put that. Thank you.
Yeah, I concur with both of you. I think to have neuropsychologists involved in the clinical team in assessing deficits that we typically don't get through a quick neurological examination will really help improve outcomes for all of our patients. Thanks for that great question. Another question that's in the chat has to do with this concept of curriculum on emergency surgery. So I think what the question really is addressing is this idea of subspecialties in clinical medicine. So, I was actually trained as a spine guy. And so when I went to Ethiopia for the first time, my first patient was a shunt case, pediatric case. And in the US, pediatric neurosurgery is a separate subspecialty from adult neurosurgery. So I learned from people like Ebenezer how to do shunt surgery. You taught me, yeah? But the question has to do with, the idea of these subspecialties, whether that fits in the paradigm of delivering neurosurgical services at the last mile, right? Let's say at a district level hospital or referral hospital. Does it make sense to have a neurosurgeon, orthopedic surgeon, ENT surgeon, or can we really address the emergency burden effectively by having people trained in some key emergency types of procedures across subspecialties, right? So they're talking about open reduction, internal fixation, C-section, burr hole. So these are proceduralists who can do the surgery, but they blur the lines of specialty. Do you have any thoughts about that? I'll go with Tariq first.
Yeah, I know, in Europe, they have become very, very strong. These emergency surgical people, emergency medicine people, and sometimes neurosurgeons have a problem with them. So I'm not too sure whether it would work that well, although it would definitely reduce the burden on the neurosurgeons, that they can then focus on other things like brain tumors or spinal tumors, etc. It is something which one can look at if we are talking about trying to improve the global neurosurgical services, definitely.
Ebenezer, your thoughts?
Yeah, thank you. Yeah, regarding our experience regarding task shifting and task sharing is since the number of neurosurgeons still is very limited. So usually the general surgery residents will be trained to do life-saving neurosurgical procedures as part of their training. And when they go out and work in the peripheries, so they usually practice or are expected to do these life-saving procedures. And the other is these health officers are trained to do emergency life-saving procedures as a master's program in our country. So this is also another initiative. And from the neurosurgery team aspects, during the years, especially when we work in a tertiary hospitals, so we tend to lose that skills to do basic life-saving surgeries like tracheostomy, chest tube insertions, because you will consult other departments. So the other point to this is so our trainees and we ourselves also have to be well versed to do all life-saving procedures in our patients when needed. I think this will be some of the important points, and this has to be parallel with the development of course, the specialists, because the neurosurgery team also has to improve, and we have to focus on that too. Thank you.
Yeah, Ebenezer, that actually segues really nicely to the next question, which has to do with task shifting and task sharing. So there was a question, at least in Ethiopia, you actually have a cadre of medical officers who are trained to do some surgical procedures. Can you give us an idea of scope of their work, how they fit into the service delivery model, and how successful that has been in Ethiopia? And then Tariq, maybe you can comment on some of the global recommendations, at least from the policy document, about task shifting and sharing. Ebenezer, let's hear from the Ethiopia experience.
Yes, thank you. So we have these health officers, so they are usually trained for 3 or 4 years to be health officers, and they will do a master's program to do emergency life-saving procedures like acute abdomen, cesarean sections, intestinal obstructions, this kind of cases. Usually for neurosurgical cases, it's not quite common to train the health officers to do life-saving neurosurgical procedures, but for other surgical disciplines, this is one common practice in our country. But I have a few experience in Malawi, so I had a chance to work there for a few months, and I have seen the health officer being trained to do endoscopic third ventriculostomy and some specific procedures. And because there is a very limited number of neurosurgeons, and temporarily that could be one option. But parallelly strengthening the neurosurgical training programs and the capacity of the neurosurgical teams also has to be emphasized. Thank you.
Thanks, Ebenezer. Tariq, what do you think? So what do ministries of health need to do in terms of task shifting and sharing?
So, I'll just give you an example. When I was training in Belfast back in the 80s, we would train because it was the only neurosurgical unit in the Northern Ireland. And there was a lot of trauma, a lot of, the sort of war was going on there. And we would train general surgeons to do simple burr holes or craniectomies and then transfer the patients to us that. It's a very, honestly, it's a very difficult question because unless you are able to monitor them, and you teach them to do a craniotomy for trauma, that's fair enough. That's very important. That's to save lives. But unfortunately, when that person is not being monitored and he starts doing something else beyond trauma, then it can become a problem. So it is double-edged sword in countries where there are very poor controls. But definitely, as you know, that we have had a lot of discussions on this topic, whether we should do it or not. I think there must be a way in between to do that because it would definitely help.
Yeah, I think I can summarize this point and in that there's ample evidence, not just neurosurgery. I think there's an evidence from the obstetrics community where midwifery performing cesarean sections, the outcomes are certainly not any worse. And I think within neurosurgery, we've done research to show that for trauma surgeries, the outcomes are about the same for people who are not neurosurgeons, but doing emergency craniotomies. So there's the argument that the quality is not as good is, I think, pretty much not true. But then there needs to be some regulatory framework to ensure that it's done correctly, right? And then giving these people the right type of recognition and protection. Okay, so let's jump around a little bit on the questions. We got some really interesting question, and this one I'm going to go to you, Tariq, because I think you might have some experience in it. It has to do with using infrascanner. Do you have any experience with that? Or yeah, Tariq, well, maybe you can explain what that is and how it's utilized.
Yes, so infrascanner is a very interesting. It's a handheld thing like the one for the traffic police, check the speed. So it's infrared rays, and you have certain points where you can check it to see whether there's a hematoma. So initially we worked on it for extradural hematomas and subdural hematomas. It is still in a clinical trial phase. Andres Rubiano from Colombia has done a lot of work on that. We recently got 2 infrascanners. It's been now 2 years, and we've been working on that. A new study is going to be now started very shortly between Colombia, Pakistan, South Africa, and with adult and pediatric children to see whether it's effective in looking at intracerebral hematomas. But I believe that it would benefit. We presently have been using the infrascanner and then doing a CT scan to compare the results. And there is some positive indication that it is helpful, but I think there's still more work to be done. But definitely it is going to be something which will really benefit in remote areas.
Thank you for that, Tariq. Ebenezer, do you have any experience with infrascanner?
No, I haven't seen it in demonstration. I have not experience.
All right, so now I'm gonna we're gonna ask a very challenging question, which has to do with role of technology companies, and in some ways it's the industry, right? what are some ways that the medical device companies and surgery companies, right? What can they do to actually lower costs instead of accelerating the cost of this care? Do you have any thoughts about that? Is it possible? Ebenezer, what do you think?
Yes, that's things which we always aspire, like, because we really have a shortage of resource, and it's always a challenge. And we tend to reuse things again and again, like even for consumable things like drill tips, giggly sauce, suctions, cautery tips. So despite that, we get shortage of like really basic equipment, and industries has to tailor and focus their markets for low-income countries. I think they have to see the demand. So what we need is not like a sophisticated equipment, but the basic sets and the basic equipment which could have impact in a lot of like lives. Like we can use it like and with this aspect, if they can refine like their products, and they need to do like a good, I guess, need assessment, and to see they have to come and see the real situations in the low-income countries to come up with the solutions. So one thing we face currently is like we have a reasonably good number of human resource development, but most graduates will not work as they are trained. Like they will go out and they don't have even the basic instruments. So I think the industries have to do like a baseline assessment and come up with solutions.
That's a great answer, Ebenezer. Tariq, what are your thoughts?
Yeah, Key, we just said that the requirement of surgery, if you compare it with high-income countries, low-income countries, there is no comparison. It's a very huge burden of disease in lower and middle-income countries. If some intelligent people understand this, they know that you may need maybe 2,000 CT scans in Pakistan. And if they understand this, I think they can make 10 times the money of what they make if they sell one CT scan. Look at China. And China is trying to develop cheap instruments, cheap equipments. And I'll give you an example. If you remember when the Afghanistan problem started, we in Pakistan collected $20,000 and we sent 20 sets to 10 different units in Afghanistan. And the WFNS Foundation sent me $20,000 and we sent to 10 more centers. And we knew that for that $20,000, we could purchase maybe only one craniotomy set. And we sent 20 sets. So, and I use those sets and I'm very happy with them. So if they realize that if they can send X number of CT scans or MRs or endoscopic equipment, they would earn much more money. But maybe I think you sitting there can put this into their heads.
Yeah. So I think to me it has to do with the governance and the authority of each country. So what I mean by that is these things that are designed to be single use. And it never made sense to me why instruments are reusable, but some of the, these single-use items are not. In the US, I remember we would open up all kinds of drill bits and, supplies. And then at the end of the operation, they didn't get touched, but they were all thrown away once they were opened and they couldn't be re-sterilized per manufacturer specifications. And I think the three of us here can agree that many of those things can be re-sterilized and used safely, right? And you were actually doing that. That's one. And then Tariq, you hit a very important point, which has to do with the market size, the emerging markets. It could be a volume play for the industry, right? If they come up with a low cost, low margin, but high volume, that can make it much more attractive commercially from the industry point of view. It's a very complicated issue. I don't know who put it. I think it's Arena that put it in there. She's smiling. It's something that I think we need to talk about more for sure. Okay, so we have just you know what? I'm just going to ask a quick question. We're at the 9:50. Let's do this. I'm going to have you, Tariq and Ebenezer, just wrap up some key points and thoughts on this, and see if you can tie it to the IGAP. That's what brought us all together. So let's go with Ebenezer. Some final thoughts.
Thank you very much. Thank you again for the invitation and like the brainstorming discussion. So in general, like I mean, for us practicing like physicians in low-income countries, so like as we discussed, small things could make a big difference, and giving attention like the health, like the international organization like WHO and international professional societies and the industries has to focus on the needs for specifically neurological disorders in low-income countries. And I think we can make a big difference with only small efforts. And from our side, we will also have to come out and show our need, demands, challenge, and what and things we achieved. And this is expected from us, I think, continuously. And thank you very much again for the invitation.
Thank you, Ebenezer. Tariq, any final reflections and thoughts?
Yes. Thank you, first of all, for getting us together. Really, I think this WHO thing on IGAP, I think it's very, very important. I think we need to look at very close collaboration with everybody because I think it's going to help the patients very much, and it would help the neurosurgeons understand the disease burden on epilepsy and even other things much more. And I think the amount of help which can get from the neurologists, the neuropsychologists, the nurses who are all here, and I see when there was an ophthalmologist from Pakistan, all these, I think, getting them together to discuss as you normally when you do their MDTs to sit down and discuss. I think this is going to be very helpful, and I think this should continue for the future. Thank you.
Thank you both. So yeah, this has been incredibly educational for me to talk about these issues. But what's more important is who's in the room today, right? And as Tariq mentioned, they're neurologists, neuroscientists, researchers, public health practitioners, nurses, and this is the spirit of IGAP, the Intersectoral Global Action Plan. It's a 10-year plan, and countries are now starting to figure out how to implement that. And I propose that each country, people like us, should create sort of working groups, right? Whether it's maybe in Ethiopia, we'll start with this kind of multidisciplinary group to engage with the Ministry of Health and saying, how can we help you implement the IGAP? It's a very broad set of recommendations, not only to double the amount of research on these conditions, but policy development, service, the care and treatment of these conditions, diagnosing them and treating them early. So it's really the door's open for us to sort of walk through, and I think it's important that we have to walk through it together. And then I think at the global level, we have the World Federation of Neurosurgical Societies, where the three of us are involved in the Global Neurosurgery Committee. We need to work with the World Federation of Neurologists, if there's a such thing as World Federation of Neuropsychologists. All the groups we need to engage at that global level. And I think I see a big role for academia, like University of Liverpool, Harvard program, Harvard Medical School. We can provide the platform, but I think the one thing that's already set up is this One Brain Health platform. Hopefully, we'll see more and more of these kind of collaborative, interdisciplinary type of webinars, and it could be the platform to help foster these and help implement the IGAP. So that's thank you for bringing us together with you. We look forward to further meetings with you. I think I have to turn it over now to Arina. Go ahead, Arina.
Thank you very much. Benjamin, I see you have a question, but we are 5 minutes from the session end. So if you type it in the chat, then maybe our speakers will be able to answer it sort of by writing. Apologies. Thank you very much, Ki. Thank you, Tariq, and thank you, Abanej. This has been a great session, and I'm really pleased to have you here because as a neurologist and sort of from my perspective, I've certainly learned plenty about how we can think and approach some global challenges for the global brain health, be it sort of, through prevention, through reducing the cost of technical equipment, or even upskilling our workforce. And I think there are many universal lessons. So it's great to be on this journey together. Very quickly before we finish, it's the sort of last segment that we do in this webinars is the sort of opportunities panel. So we want to also act as a platform which shares different opportunities for engagement, for conferences, and for the events. So I'm just gonna share my slides very quickly and just mention a few upcoming opportunities. So this is showing now. First of all are the events, and this is the last clinical exchange platform this year before we regroup again in January. So I just want to highlight those with deadlines for registration and discounted rates that are sort of before the end of the year. Tariq has already mentioned the first International Global Neurosurgery Conference. So that will be in Peshawar in Pakistan. The registration is now open, and that will be opportunity to meet our speakers again and possibly in person. There is also the 18th World Congress of Neurosurgery, and that is in Cape Town, and that is happening in December. So it's sort of last call to register for that one as well. Unfortunately, abstract submission is now closed, but there will be lots of great research presented in the opportunity network and sort of build on the connections to enhance global neurosurgical care. As a neurologist, I'm also deemed to sort of even it out with the European Academy of Neurology Congress. That is happening in June, end of June next year. But the reason to highlight is now is because the abstract submission is open until sort of mid-January. And actually for researchers and residents and fellows, there's usually good sponsorships, and there are 250 bursaries. So if you submit an abstract and get selected for a presentation, you have an opportunity to attend the Congress for free with registration fees covered and also accommodation covered. So that's something maybe to think over during the Christmas break as the deadline is approaching soon after. We also want to highlight PhD fellowship opportunities. The first one is based in the UK and is open for those who have a license to practice in the UK. It is based at the Newcastle University. It is a position for 3 years with teaching and on-the-ground research in Parkinson's disease prevalence in Kenya. And this is actually starting early next year. So this is sort of last call from our colleagues in Newcastle to apply for this fully funded position, which would lead to acquisition of a PhD. Unfortunately, the applicant needs to be UK registered and UK qualified. Next one is an international opportunity. So again, just to even it out, are the Global Health Fellowships at Stanford University, and these are open to 24 scholars from countries in Africa, which actually practicing and resident in Africa, and pretty much all African countries are eligible. This is not limited to any particular specialty, but it can be neurology, it can be infectious disease, it can be surgery. And what happens in that program is that selected applicants, they come up with a sort of service need or a skill set that would be very helpful in their settings for their center. And they get invited to Stanford to acquire those skills and get mentorship for a period of several weeks. And then they go back to the home countries and implement those solutions and perform quality improvement projects for a subsequent year. This is a really great opportunity, and applications will be opening early next year. So that's also something to think about before the next clinical exchange platform. The last two announcements are about sort of pooling resources for global neurology and global brain health. And in particular, we talked a lot today about IGAP, which is sort of the plan for improving neurology care globally. And WHO is actually collecting tools that could go into sort of uniform toolkit. So they are particularly interested in hearing about evidenced, peer-reviewed, published solutions or case studies. For example, toolkits, pro formas, record forms ways to organize healthcare systems from settings all across the world, and they can be submitted with a sort of evidence and examples of implementation, and they will be considered for implementation toolkit by the WHO. So this is if you have a solution, if you have ways in which you improve neurological or neurosurgical care in your setting, and that's a note also to Ethiopia and Ebenezer. This is something you can submit, and that can be then included in the WHO toolkit, and that's open until the 15th of December. And with last minute to go, we are also delighted that we've launched our Knowledge Exchange Hub at the University of Liverpool. This website has been in building for sort of the last few months. We now have a proportion of it where you can watch sort of previous webinars and catch up on the ones that you might have missed. We also have a registration website for the neuro resources, so some of the resources that our team developed. So this include uniform case record forms. They include some neurological definitions and also some clinical guidelines, particularly with the sort of focus on COVID-19 and neurological conditions, because that's been interest of our infection neuroscience lab. So we encourage you to register, and that way you can stay in touch and collaborate as well in the future. And our next exchange platform will be on the 26th of January at 2 p.m. London time, and we'll be focusing, we'll be going back to neurology and having guest speakers from the World Federation of Neurology to discuss sort of similar themes, but on the neurological spectrum. So thank you very much for attending. I hope this was a valuable session for you. There will be a request for feedback. We always look forward to getting your thoughts and seeing you in the future webinars. Thank you very much to our speakers again, and thank you for all the attendees.